There we go. So I want to first start off by introducing Dr. Stephanie. So Dr. Stephanie, she's an associate clinical professor here at UC Irvine and Children's Hospital of Orange. And she's a board certified urologist with a subspecialty and certification in pediatric urology. We have the honor of having her after she did her medical doctorate at the University of Kansas School of Medicine and completed her residency in urology at the University of Kansas Medical Center. She subsequently matriculated to Vanderbilt, where she completed her pediatric urology fellowship. She is currently the associate program director at UCI and the fellowship director over the pediatric urology fellowship. What's really, really cool about having her is that she's also a board member of IVU Med, an international urological NGO, and volunteers biannually in Africa, and shares her expertise in pediatric urology globally. And yeah, it's an honor to have her today.
Thank you. That was very nice of you. Excited to be here. And
then Dr. Jamie Landman, he has, I have had the honor of working with him for a few years, but he served as the chair of urology here at UC Irvine since January of 2011. He was formerly the director of minimally invasive surgery at Columbia, and he just decided to come to somewhere a little bit more sunny. So he's here at UC Irvine for over a decade now. Dr. Landman is a respected and international expert in the management of kidney cancer and is a pioneered and recognized expert on the application of minimally invasive techniques for the ablation of kidney cancer. He's helped redefine the diagnosis of kidney cancer by developing novel diagnostic biopsy techniques and has really provided the field and, more importantly, patients with a more precise treatment of their disease. He also directs a course with the AUA, as well as a small renal mass mini fellowship at the University of California, Irvine. So we're really, really blessed to have him today. Perfect. And then I believe Dr. Chi has joined us. Is this correct?
Yeah, sorry to be a few minutes late. Just wrapping up.
No worries. Hi, Dr. Chi. So I'm just going to introduce you real quick. So Dr. Chi, we're very honored to have you with us today. For those who do not know, Dr. Thomas Chi, he earned his medical degree from UCSF School of Medicine. After graduating, he completed 2 years of general surgery residency training and then a fellowship residency training at UCSF. He continued to finish a fellowship in endourology and the laparoscopy under the mentorship of world-renowned urologist Dr. Marshall Stoller. During his fellowship, Dr. Chi was awarded grant funding from the NIH and the AUA Care Foundation to research the fundamental mechanisms underlying the formation of urinary stones. And what was really cool to if you ever read his publications is that he's actually developed a novel model for the study of kidney stones utilizing the common fruit fly, Drosophila melanogaster. He joined UCSF as a faculty member in 2013, and his clinical interests include the care of patients with kidney stones and those in need of minimally invasive surgery. He's also established the registry of stones of the registry of stones for kidneys and the ureters, which is the first kidney stone registry of its kind for tracking patient clinical outcomes. And he's an internationally recognized specialist in the use of ultrasound in the management of kidney stones to prevent patient radiation exposure. So it's an absolute pleasure and fortune to have you guys here with us today.
I got to remember to ask how on earth you get kidney stones into a fruit fly. I'm curious about that. So I will do a quick introduction. We have our two students here, Kyle Shepard, who is a student from Rocky Vista University, which is the university I also come from, so we're good friends. He is a third-year medical student. He'll be presenting one of our articles. And then we have Aditya Sathe. He is a third-year medical student as well. He's coming from the University of Tennessee Health Science Centers. He'll be presenting the other article. So our topic this month is genitourinary trauma and imaging. So we're going to be talking a little bit about one instance of how we deal with trauma in the genitourinary system and a little bit about imaging. The articles for this month are the urethral reconstruction for traumatic posterior urethral disruption, outcomes of a 25-year experience. That will be presented by Kyle Shepard. And then after that, we will have the article Ultrasound Guidance for Renal Tract Abscess and Dilation Reduces Radiation Exposure During Percutaneous Nephrolithotomy. That will be presented by Aditya Sathe. So I will allow them to share their screens. We'll start with Kyle. We'll have him share his article. After that, we can have some discussion. When the discussion kind of dies down, we'll move on to Aditya's presentation and some discussion after that. So we'll start with Kyle.
All right, thanks, Kaylin. Everyone hear me all right?
Yes.
Cool. All right, let us share the screen here. There it is. And can we see the presentation? Perfect.
Looks good.
All right. So, like Kaylin said, we'll be talking a little bit about posterior urethral injuries and this study that came from Kuperberg, MR et al. From 2007. Just to start off, I'm going to kind of go through some basic clinical manifestations and things like that of posterior urethral injuries before we get into the nitty-gritties of the paper, just to kind of give us some context. And to start, we have an overview of urethral anatomy, and we're specifically going to be focusing on the posterior urethra coming from the bladder neck, the prostatic urethra, and the membranous urethra. You can see that the bulbar urethra and the membranous urethra are right next to each other, and often the bulbar urethra is going to be moved in order to kind of make up a difference in injury in the posterior urethra in connecting the bladder to the rest of the urethra. And as far as the etiology, about 90% of cases involve pelvic fracture or other blunt trauma from motor vehicle accidents or other occupational injuries. And as far as how you're going to see it, you'll be looking for injury to the genitals surrounding area, blood at the urethral meatus, perineal hematomas, or a high-riding prostate on the DRE. This is all suggestive of a posterior urethral injury. And if you're thinking, hey, this person probably has a posterior urethral injury, some imaging can be helpful, especially a retrograde urethrogram. And as I was reading kind of on up-to-date about this diagnostic study, it was interesting that proper positioning was very helpful, because it said that if you just have an anterior posterior view, you can kind of miss the posterior prostatic and bulbar urethra areas. And so this image here is how, I think this image here is kind of how they suggest the patient be positioned in order to get an optimal view. And we'll see kind of how that optimal view can be presented. Because if you see on this right with the image B, you can see the bladder up here. And then on the bottom of the image, you can see the penile urethra. And in the middle there, you can see where they have strictures and other obvious defects. And there's another image that I pulled that can also help illustrate the difference in the normal urethra versus this injured, fibrotic, strictured, or what have you, posterior urethra. And as far as I understand it, a lot of times you'll put in a suprapubic catheter and inject contrast into the bladder, as well as inject contrast up through the penile urethra to kind of get the contrast at both ends of the stricture in order to get adequate visualization. Some treatment options are immediate and some are delayed. And as we'll see, most treatment is in favor of delayed while you have stabilization of maybe other trauma injuries to the pelvis. And as those start to stabilize, you can then go in and make repairs to the urethra. In the meantime, a suprapubic catheter is often used. As far as immediate treatment options, there's immediate open repair with anastomosis of the urethra. However, I think this is going out of style as there are high rates of impotence, incontinence, and stricture recurrence. And those three things are kind of the main, I guess, outcomes of what you want to accomplish with this kind of repair. You want to be able to have erection function. You want to be able to have good continence and voiding function, and you don't want to have the stricture come back, so you have to do another operation. And as we'll see in this study, the main outcome that was focused on was stricture recurrence, and some limitations of the study is there was not maybe as much ability to measure impotence or incontinence in the way that the study was designed. Another option is immediate endoscopic realignment, where you place a catheter across the injury. The literature, from what I read, is a little bit mixed on the benefits and risks of this procedure. Maybe it'll start to be fleshed out in the coming years. And immediate open realignment, aka not endoscopic. I read that this has a high risk of significant bleeding if you encounter a retropubic hematoma and that gets disrupted. Like I was saying about delayed treatment, the AUA seems to be pretty steady on this the past few years. In 2016, they recommended delayed treatment after major injuries are stabilized. And in 2020, that seems to hold true about immediate management remaining controversial and traditional management being delayed urethroplasty. And the delayed options are very, very similar to the immediate options, except they're, after a period of time where you have endoscopic realignment. These report a high rate of stricture reoccurrence, as well as endoscopic repair. It's not really recommended anymore, as far as I was aware, due to stricture recurrence and the potential for injury to the surrounding organs, such as the rectum and other areas. And then delayed open repair, which is what this study talks about, is apparently the most widely used option. A suprapubic catheter is inserted for about 3 to 6 months before operating. That brings us to the study that was very interesting to read. And I'd like to take this slide to just kind of talk about what the paper is and what it isn't, just so we can kind of, it's easy to get caught up in a study and be like, oh, these results are amazing. This is revolutionizing the field. And maybe it is, and maybe it's not, but it's, I think, important for us to get some perspective on what the paper is trying to say and not what we want it to say. So what it is, it's a case series reporting outcomes of a single surgeon over 25 years. And there are descriptive statistics regarding those outcomes. It's not a randomized controlled trial, not a cohort, not a case control study. Not saying that that makes it a bad study, it is what it is. And the next 2 slides I've got kind of help us understand where case series go in how we interpret this evidence. This image kind of puts case series right around here, around case controls and case reports. Obviously, we have a wide foundation of bench and animal research, and then kind of the pinnacle, the go-to that everyone always wants to see is randomized controlled trials and meta-analyses and things like that. Although I've got a second image here that I wanted to put in to make a point that image wasn't the be-all end-all of how we should interpret evidence. This is a slightly different pyramid, if you will, that was put out by Dartmouth and Yale in 2006. And you can kind of see there's a similar trend, but the point I wanted to make between these 2 images is even in evidence-based medicine, there seems to be room for gray area, room for debate, room for nuance. And I think that's important as we kind of go through this study. And speaking of the study, the methods are as follows. We had 163 patients in this area from 1979 to 2004 who had a posterior urethroplasty done. All of the non-traumatic cases were excluded, and some non-traumatic cases included radical prostatectomy, pelvic radiation, and some other ones. And that narrowed it down to 134 patients. The surgical goals for the study were a complete resection of the fibrotic tissue and a tension-free anastomosis of the urethra. And the outcomes were measured via a strict definition and a permissive definition. Now, what does that mean? That's mostly looking at the stricture recurrence. So any secondary intervention after this first one was considered treatment failure via this strict definition. But a little bit more permissive way of looking at it was, did we have any mild recurrence that was successfully managed with a single direct vision internal urethrotomy? And as we'll see, looking at those two definitions kind of gives us a good perspective on this method of treatment. This is actually from the study, where they kind of give an image about how they approach the posterior urethra and how the resection is supposed to go. Oh, you can kind of see that you have the bulbar urethra kind of mobilized and moving around so that you can move it to where you need it to get to the prostatic urethra in connecting the two ends. Their procedure as listed was that a flexible cystoscope was introduced into the bladder to visualize the proximal end of the urethral injury. And the bulbar urethra was mobilized, as we saw in that last picture, to give it enough wiggle room, I guess, so that you don't have tension pulling on your sutures. And then if more urethral length was needed, they often did a partial or full resection of the pubic bone, because as we'll see in the next couple of slides, the pubic bone can sometimes get in the way of your reconstruction. This image, also from Up to Date, gives us a visual of how that anastomosis can happen. The longer normal loop, we can resect out some of this tissue and kind of almost jimmy rig it. It looks like jimmy rigging in this picture, but I'm sure it's much more sophisticated than that. And connecting the prostatic and the bulbar urethra together. In this image, we can kind of see how a pubectomy would work and how that might be beneficial in reducing tension on your anastomosis. I also want to put a little bit of emphasis on image D, where they have some rerouting of the corpus spongiosum with the urethra in it, kind of around the corpus cavernosum here. And the authors typically did not use that kind of rerouting method. And I'm not entirely sure why. I just thought it was good to note, since this image shows the rerouting. Another image we've got is of the anastomotic technique. I think the one on the left is a much more simplified version of the technique, whereas the one on the right was from an image from the study with kind of a lot more sutures in there, which makes sense. Anyways, talking about the results of the study, in about 30% of the patients, they had to split the corporal bodies, which was talked about between image B and C. You can see they're kind of pulled apart a little bit. And either partial or complete pubectomy in 26% of patients. However, that was a number of 34. We've got to keep in mind that we have 134 patients in here. So it's good to keep in mind what those percentages mean in terms of number of people. And patients with a closed bladder neck on imaging were more often required pubectomy. And then this I thought was interesting is there was a big trend away from pubectomy post 1996. I'm not really entirely sure why that was. Maybe the techniques were getting better. Maybe the traumas were less severe. Maybe, I don't know, not entirely sure. The study doesn't entirely elaborate on that as far as I was aware. But there does seem to be a trend, and I don't know if this is a trend that's reflected in common practice, since this is the outcomes of a single surgeon, but I guess that remains to be seen. as far as their main outcome of treatment success, if you use their strict definition, 84% of the patients needed no further treatment. If you use this permissive definition, where you have one instance of mild recurrence with one managing procedure to manage it, 93% needed no further treatment after that. So it seems like, pretty good outcomes from what I could tell. This is also documenting their outcomes, and looks like most of their follow-ups are these vertical lines that you see. And it looks like the vast majority of those follow-ups were at less than 50 months. I'm not entirely sure what a normal follow-up period is, but I thought this was interesting to include. As far as interpretation goes, I was very hesitant to put any kind of interpretation on this, but it does seem that this method is a useful, successful option for posterior urethral injury. And as I was thinking about this, this paper came out in 2007, and so I'm not entirely sure where the literature was at in 2007, but I could definitely see papers like this in the last 20 years leading to kind of this widespread treatment practice of delayed open repair being the most widely used option. Some limitations reported from the authors was that there were unclear measurements of continence and potency, which are pretty huge quality of life outcomes, and that could definitely be better explored. And then another thing they mentioned was that the severity of trauma was not really quantified, calculated. It was not easily pinned down. And so there was either trauma or not trauma for their exclusion criteria. So maybe severity of trauma might have implications for treatment and outcomes. That's all of my slides. I did have one question that I wasn't really sure of how does a single surgeon versus multiple surgeons experience affect the quality of evidence in a study like this? And I guess I'll turn that over to you guys.
Thank you, Kyle. Dr. Chi, Dr. Stephanie, Dr. Lamon, do you have any insight on this?
So I can speak a little bit on perspective. So it's a nice paper, and it actually came out of UCSF. So I assume most of the folks or students, at least on the call, are interested in urology. So one of the grandfathers of trauma and reconstruction, Dr. Makinich, who's the middle author on that, is a professor emeritus here, a wonderful guy. And I think that recognizing that, if he didn't start off as a trauma surgeon, he kind of created this whole field out of nothing because people were just getting shot, and then general surgeons would go in there and take the kidneys out, throw them in the bucket. And so I think that he was working at the county hospital with trauma and realized, gosh, we could probably do that better as urologists. And so was interested in that and kind of built a whole field around that. So following interesting questions is good. Now, one of the things that trauma reconstruction suffers from is because, it's not urethral injury happens, but it's not like this the most common thing ever. I mean, there's a lot more cancer and a lot more kidney stones and a lot more other stuff out there. And so I think that everybody everywhere for any question would love to have multi-center, multi-surgeon, large prospective data to really answer questions like the thing you're getting at, which is, okay, let's say you pull apart the plumbing, do you put it together right away or do you wait? Because, there's lots of upsides and downsides of each. If you're trying to put together right away, if you can imagine, a lot of these patients, if it's traumatic disruption, a lot of times we're seeing in the context of like a car crash or an automobile accident or some type of really traumatic incident. And so you got the orthopedic surgeons there working on the pubis, and you've got patients bleeding to death. And so, are they really going to be like, hey, urologist, I'd like you to stick a catheter in there and put it all together right now? So that's not probably the most important thing in that moment. And so that generates some of this debate. But if you wait to do it later, then all the techniques that you saw in terms of, well, what if you run out of length or the scarring is really bad? Like, what do you do then? So that's kind of the core of the question. And so within trauma and reconstruction, because there's not huge numbers, this is a field where for many, many years, it really has relied on kind of single surgeon evidence of series. And so only now there's a society of actually many of Dr. McInish's former trainees who've come together, and now they've actually created what's called the society called GERS, General Urinary Reconstruction Society. Within GERS, they've created a multi-center collaborative where people are putting their data together. So hopefully these types of questions over time can be answered better. So, you know, whenever you're thinking about doing any type of research in anything, I liked your pyramid schema. So you always want to get towards the top if you can, multi-center, prospective, randomized, high quality data. And, you know, when you got stuff that's kind of not so frequent, that's why it's hard to get to more than a single surgeon's experience. A couple thoughts.
Thank you, Dr. Chi. That even sparked a kind of thought in my mind. Sometimes with studies, when you're hoping to do something prospective, you always have to consider ethics as well. Sometimes in a trauma scenario, you don't have the opportunity to consent the patient to a randomized trial and do one way versus another way. We kind of have to go on whatever evidence we have that says one method is the best. So in this case, in trauma settings, sometimes you run into ethical issues when you're trying to create larger studies with patients and you want that ideal randomized setup, but it's not always possible. So sometimes the best studies we have to go off are these kinds of studies where someone has just meticulously recorded what they've done over, in this case, 25 years and shown what worked for them.
Yeah, another comment I had was that, Kyle, you mentioned like some of these patients prior to their second urethroplasty had prior urethroplasties. I was wondering, you know, if these patients had prior urethroplasties and they've had like fibrotic tissue removed or reconstruction already, how did that affect, you know, their second urethroplasty or posterior urethral reconstruction? Would they have like less room to work with, or did that affect outcomes in any way for these individuals, do you think?
Not that I remember reading, although I do remember reading that patients earlier on in the series had less prior urethroplasty done than patients later on in the series. And I'm not entirely sure what the reason for that was.
A lot of times in these patients, your first shot is your best shot. So I think that's a lot of why, you know, delaying and coming in. And then, you know, you guys will learn there's lots of big names in urology, but McInish is a huge name. And it, you know, and this is something he does. You can't see the average general urologist saying they do this many at all. I mean, this is, you know, really a super subspecialty. It's completely different than an anterior urethral stricture. So this is its, you know, own unique class. And it's one of those things where even if I was confronted with something like that, I'm going to, you know, consult with my adult recon specialist, Dr. Gelman. And, you know, because you really want that first shot to be the best shot, because after that, it gets pretty ugly. So.
Just to follow up on that, Dr. Stephanie, if someone had a prior urethroplasty and you consulted, typically what kind of route do you guys typically go down to manage these types of patients, these complex patients? Is there like a standard protocol for these types of patients?
I mean, if someone comes to you from the outside, you know, obviously I think a lot of times doing your own imaging, I like to do, and Dr. Gelman especially, you know, doing your own imaging and doing your own retrograde VCUG, repeating things, I think is always good. You know, cystoscopy is something that people do very easily in the clinic in the adult world. In the peds world, we don't really do that. We're not really set up for that. But yeah, and I do know, and I know we had mentioned earlier how I go to Africa. A lot of times I see a lot of these traumas when I go to Africa and older kids. And I honestly, a lot of times I won't mess with them, so to speak, because they'll already have a diversion, so they're protected. But if I know, one of the recon guys is coming next round, or if I bring a recon guy with me, then we'll do it together. Santucci has been on a trip with me before, and it was great because I was like, this is you, you know, but because I just want to make sure it's done correctly. So if they're safe and they're diverted already, then I'll wait for that more experienced person to come in and do that.
Great, thank you.
Are there any other questions before we move on to the next presentation?
I just wanted to add the one thing that I think we've missed is that the expertise to do these kind of surgeries is not always available. And we talk as if we're always at a tertiary medical center where there's somebody routinely within reach who can do these operations. A lot of this is not really debatable because many urologists are not comfortable doing complex urethral reconstructions. And probably even if they did try and do them at the time of the accident, wouldn't do a very good job. So when Dr. Stephanie says your first shot at doing it is your best shot, that doesn't mean you have to do it right away. Your first shot may be in a delayed manner with somebody who has a lot of experience, which is probably better than somebody like myself, who wouldn't do a very good job with a urethroplasty. It's just outside my area of expertise. But great discussion. I think we should move on to the next article. What do you guys say?
Thank you. Yes, so Aditya, if you're able to share your presentation, we'll let you take it.
All right, thanks guys. Can you guys see the screen and hear me okay? Awesome. Well, again, I'm Aditya. I'm a third-year student here at the University of Tennessee College of Medicine. As a third year, my knowledge is still limited, about 2 months into my clinical rotations, but I really welcomed this opportunity to learn and present some really cool work. So huge thanks to Dr. Chi today for being in attendance, kind of alongside reading the paper I'm presenting. Ended up going down a rabbit hole reading about your other clinical and academic efforts. So excited to share with the audience today some of your work. Please do feel free to chime in at any point if you'd like to add something. So the article I'm discussing today is titled Ultrasound Guidance for Renal Tract Access and Dilation Reduces Radiation Exposure During Percutaneous Nephrolithotomy. So before we actually get into the paper, I wanted to share a brief history of kind of the innovations that led to modern PCL and give you a better appreciation for sort of the iterative approach that's been taken to manage kidney stone disease. So it wasn't always intuitive that we could access the urinary tract and its anatomy directly from the skin. Really, it was a series of discoveries by clever urologists to ultimately access and then manipulate the urinary tract in what we now call an antegrade fashion. So in 1955, while trying to perform a renal arteriogram, actually, Dr. William Goodwin of UCLA ended up inadvertently placing a needle into the collecting system of a patient's kidney. And then he left a tube to drain the kidney just in case, thereby placing the first, modern day nephrostomy tube. Then a few years later, as optical endoscopes were really taking flight, Dr. Marshall of Cornell did the first open exploration of the renal pelvis and ureter with the use of a camera. Now, it wasn't until 1976 when two Swedish urologists first figured out how to harness these two technologies and actually remove a kidney stone through the nephrostomy tube. And then with further advancements, over many years, we were finally able to use shockwave and ultrasonication to actually fragment and remove larger stones. So it just kind of gives you a sense of the innovation that's been a selling point for the field of urology for decades. Kind of holds true to the line in the Hippocratic Oath that says, "I will not cut even for the stone." And so the initial step in performing PCNL is kind of first gaining access to the collecting system. Because the kidneys sort of lie in close proximity to surrounding structures, the access is pretty important to reduce complications and then maximize your stone-free rates. So there's currently two main modalities for visualizing the tract for access. First is the fluoroscopy, which involves kind of injecting radiocontrast through a retrograde catheter. And it's more of an involved procedure that requires rotating your C-arm between two different angles and continuously correcting the path of the needle as it's advanced. And then the second one, which we're kind of assessing for its merits today, is Dr. Chi's brainchild, which is ultrasound guidance, where we're able to really visualize the calyx for entry in an antegrade fashion with really real-time tracking of your environment around the kidney. So when we look at patterns and surveys conducted over recent years, and certainly this is changing, we notice that in the US and kind of around the world initially, the majority of urologists, the ones that aren't using fluoroscopy, are deferring to the interventional radiologists for access. And how do the IRs get access? Of course, by ultrasound. You know, they don't really have a fancy fluoroscopy suite to work with. And so it sort of begs the question, what's limiting the urologist from being able to take control of all components of the procedure and be really involved in their patient care? So here I'm actually citing a 2017 study, which looked at a pretty sizable registry of all PCNL procedures performed in the UK. Now, 5,211 of which had information on who was actually able to get the access, you know, urology or IR. And so they first showed from the years of 2012 to 2017 that the rates of access between urology and IR in general had seemed pretty stable, and more so the rates of success and complication aren't too significantly different either. Now, ultrasound guided access is used in about half of these cases. And then of those half, 60% involved the interventional radiologist obtaining the access. And so that's kind of getting people to think the urologist is not any less of a surgeon or an interventionalist, that they can't perform the skill. But really the main takeaway here is not to engage the two fields in competition, but you know, rather to really observe that this is a really learnable skill with some clear advantages. So when we start to think about some of these advantages, one of the main drivers of this push to adopt an alternative technique for PCNL is the concern for excessive radiation exposure with fluoroscopy. And that's really the thesis of the article that we're discussing. Now, most physicians who work with ionizing radiation for diagnostics really underestimate the radiation doses associated with the procedure. So numerous studies in the literature have shown that occupational exposure dose can still be detected, which kind of raises concerns for long-term effects that really haven't been studied. And it's really an important consideration as well from the patient perspective, because patients with kidney stones already have a large imaging burden in the workup of their disease. So kind of Dr. Chief's paper cites a study shown here on the right that does in fact demonstrate radiation exposure to the surgeon and other personnel with fluoroscopy. And, you know, it's kind of established that these levels are still within the safe limits, but we kind of approach radiation a little bit differently using what we call the ALARA principle, which I discovered recently. And the ALARA is basically, you know, a tenet that says we should keep the radiation doses as low as reasonably achievable. So that's the ALARA acronym. So if we can kind of really prove that ultrasound guided PCNL is a skill that can be taught and, you know, it's safe and still has favorable outcomes, then we really make a strong case for its adoption by urologists all over. So I wanted to briefly go over the specifics of the PCNL procedure. And I found by that kind of trying to understand the procedure in depth, I was really able to appreciate the utility of the ultrasound guidance in a lot of these steps. So just a brief inventory of the tools. You have the ultrasound and then the needle for access. And then you establish the operation channel with a series of dilators, a fascial dilator and a balloon dilator over a guide wire. And then you fragment the stone and then you place the nephrostomy tube for ultimate drainage. So your classic PCNL, you know, regardless of how you're visualizing the collecting system, involves a few key tasks. So I thought I'd just show you a simple, useful animation to kind of get a better understanding of the mechanics and the technique. And then you can kind of follow my roadmap here if you want. Hopefully this will work. And I kind of just like to skip to
urine drops. Connect an entry needle straight into the calyx until contact is made with the stone. Remove the core of the needle. Urine drops confirm access into the kidney. Insert the wire through the needle sheath. Deflate the occlusion balloon and remove it. Slide the needle sheath off the wire and remove it from the kidney. Guide the burn torqueable catheter over the guide wire and into the open area of the renal pelvis. Back the guide wire up to the stone, leaving a portion of the wire's tip outside the catheter. Twist the catheter handle to advance the wire past the stone towards the ureteropelvic junction, down the ureter, and into the bladder. Remove the catheter. Slide an 8-10 French dilator sheath over the guide wire. Slide the 8 French dilator past the stone and into the upper ureter. Slide the 10 French dilator past the stone and into the upper ureter. Remove the 8 French dilator. Insert the stiff working wire through the 10 French dilator down into the bladder. Remove the 10 French dilator. Incise the skin in the back through the connective tissue in order to widen the existing puncture. Slide the balloon catheter over the stiff wire up to the stone. Inflate the balloon to the appropriate pressure. Slowly insert the renal sheath, twisting clockwise and counterclockwise until reaching the stone. Deflate and remove the balloon catheter. Both wires remain in place. Insert the nephroscope into the sheath. Guide the pneumatic and ultrasonic lithotripter through the working channel of the nephroscope. Perform lithotripsy to break up the stone. The time of destruction varies based on the type and density of stone, available tools, and lithotripsy devices.
Okay, I'll kind of stop there. All of that kind of seems involved, and generally for large stones, PCNL with fluoroscopy gets the job done. But we kind of want to understand what components of the procedure is ultrasound actually useful. And there's really 3 domains that I was able to observe the strengths in. First, obviously, for accessing the kidney, and then second, for establishing that operation channel with successive dilations. And then third, really for, great visualization in complex cases with sometimes, even greater detail than fluoroscopy. And so I'll share a really cool tweet by Dr. Chi here in a sec. So for renal puncture, really the greatest strength is the ease of use. You can really use any ultrasound probe in both the prone and supine positions. And then regardless of the desired location of puncture, upper, interpolar, or lower polar axis, can kind of be done using just one longitudinal view of the needle entering the target. So you kind of see here that you see the stone with this arrow, and then you can kind of see the needle being entered, in the calyx that you've chosen. And so it's kind of easy to identify that calyx because, in the prone position, when you're sitting there, when the patient's sitting prone, that calyx that you're going to choose is most likely going to be that posterior calyx. So you're going to have a really easy time visualizing it and actually entering it. Now with tract dilation, that's where it gets a little bit trickier. And here's kind of what things look like after you've gotten your perfect access. And you see the needle there. And in the top right here, the white arrow is pointing to the guide wire. And one of the first things you notice is that it looks really bright. And that kind of reflects the properties of the wire itself. And it's usually made of like a metal piece that's highly echogenic. Now, the cool part is that the fascial dilator material is not echogenic, so it's pretty much invisible. And then once you advance that dilator of the wire, you actually see the dilator obscure that nice bright guide wire. And so that's shown right here in the bottom right with that dotted line there. So you can see the differences between this here, where you see that really bright echogenicity of the guide wire, and then it's kind of being obscured by the dilator as it's going over the guide wire. And right when you continue to see the brightest portion of that guide wire as you're advancing it down, that's where you're really able to locate the tip of the dilator. So really a clever technique, and I'm sure Dr. Chi will be able to elaborate on it and kind of give us an idea of how he's been teaching it to his residents. And then the third kind of, in my opinion, the coolest application of the ultrasound guidance is really the biplane visualization as you're doing the procedure. So with ultrasound, you're kind of able to scan for any concerning pathology, avoid critical structures such as the colon, the pleura, and then ultimately, decrease the risk of advertent injury because you're just getting such a nice view of everything. This is a really great tweet response where a colleague sort of posed him the question, how do I even get access to a calyx, that's completely filled with stones, or a Staghorn calculus? And so with ultrasound, he's kind of still able to precisely find an entry point where he's kind of dubbed the crescent moon sign. So make sure you turn on your tweet notifications so you can go read about it when he actually publishes the paper. So how did patients in the study actually do? So they had 38 patients in each group, and the paper actually reported quite favorable outcomes. And of note here is the stone-free status. Kind of more impressive in the ultrasound group, you can see that. Almost a perfect stone-free rate. There was one Clavian grade 2 post-op complication, and it was a female patient that kind of just ran a high post-operative fever but was managed successfully. So no real concerns there. And then also a really, drastic decrease in the radiation exposure dose and time for the fluoroscopy. Really the only reason that the ultrasound group column is not 0 is because fluoroscopy was needed in order to confirm the nephrostomy tube placement. So really, when given full consideration, PCNL seems like a really teachable and accessible skill for all urologists to have the opportunity to learn. But if you're still not convinced, here's a few more selective advantages. First, it really eliminates the need for any kind of retrograde, urethral catheterization, and then use of contrast media, and especially relevant for patients with kind of any existing azotemia. Second, there's important ergonomic considerations. A recent study found that 64% of endourologists actually have orthopedic complaints related to PCNL. So not having to wear lead, every time you're using, the ultrasound for PCNL can kind of reduce physician fatigue. And then third, it's really good for populations such as pregnant or pediatric patients where we're trying to avoid radiation exposure altogether. And then fourth, I think the most important is that it's kind of really a skill that can be honed in a short amount of cases. So the paper actually demonstrated, and then other work kind of demonstrated that it's really only like 6 cases that are needed for proficiency, even amongst the residents. So there are a couple of disadvantages. I'm sure they're being addressed with current research. So as of now, it seems to be remaining like a 2-man procedure because the ultrasound probe isn't really fixed in space and kind of has to be held stable so you can remain in the same plane. And then, like I mentioned, at the time that this paper was published, the fluoroscopy was still needed for the final step of the procedure, which is the nephrostomy tube placement. And thankfully, in a more recent paper, again by Dr. Chi's group, the nephrostomy tube placement was actually achieved by ultrasound as well. And then, as we saw earlier, the patients in the ultrasound group, as I mentioned, had 100% stone-free rate. And that kind of might be attributable to they actually found a lower BMI in the ultrasound group. We know that obesity and high BMI can affect your baseline risk of kidney stones. So definitely a factor to consider in the analysis. And then really the key to like widespread adoption of this technique is to pick healthy patients who have more favorable characteristics. And that really opens up, if you have hydronephrosis already, if you have a non-Staghorn calculi in a healthy, non-obese patient, really opens up that renal pelvis and creates a almost dramatic anatomy that's easier to work with. And then finally, there's new avenues, for possibly developing a whole contraption or apparatus that allows the ultrasound to be fixed on one end so that the whole case can really be carried out by one surgeon alone. And so that's kind of it. Wanted to give a special thanks to everyone who gave me the opportunity to present. Really had a good time learning about this. Happy to open it up to Dr. Chi or anyone else on the call.
I'm happy to share a couple comments. First, Aditya, thank you for your presentation. It's very well done, and thanks for inviting me. I mean, it's nice to be here. So the paper that you pointed out, I think that there was lots of things. First, you were very nice to say that it's my brainchild. I mean, people have been using ultrasound for a really long time. We simply kind of figured out how we could make it palatable for urologists. And so in the other people you talked about from the UK, folks have been sticking needles in the kidneys under ultrasound for a long time, and interventional radiologists do it every day. And so I think in many ways, urologists simply stuck with one technique and didn't try something else. And so a lot of this work has been trying to shift that needle a little bit, no pun intended. towards ultrasound for a lot of the benefits that you talked about. I think that while ultrasound in itself, has kind of shifted a lot of the way that we do our percutaneous surgery work. I'll offer a couple of comments on the paper itself, because I know many of you are probably thinking about maybe urology, maybe an academic career, and that paper took us like 2 years to publish. And before we were talking about series, multi-surgeon, this is a single surgeon series, and we were just trying to make a point. And at the time in the urology literature, really in all literature, when it came to using ultrasound for percutaneous nephrolithotomy, there was about 5 papers in the literature then, and most of them are from China or India, where they do this frequently. And so we put this, we experienced this, and then we said, okay, we should describe it and try to understand it better, and how does it affect our practice? And so we came with a hypothesis. We reduce radiation exposure. It's kind of an obvious hypothesis, and present the concept. And everybody was really excited about it, and we shopped it around. So you submit your first paper and you put it to some place, and they hate it, and then they'll give you some comments. You try to revise it and you put it again. We probably shopped this paper around in 6 places before they actually published it, and it ended up in Advanced Urology, a very nice journal. And I make that comment to say that if you're excited about something and you think it's a cool idea, and it pushed you to do something interesting, don't give up, because so much of academic medicine is rejection, like mountains and mountains and mountains of rejection. And so you have to let the process and let the outcome kind of hopefully take care of itself. And if you've got an idea that excites you, you can hopefully make something of it. So I'll offer that kind of as a comment around the crafting of this actual paper itself. It was, that in itself was a journey. The actual, the major point of the paper was really just to present this concept that, within urology for percutaneous kidney surgery, we really can be doing this in a way. Nowadays, 97% of the time, I don't even wear lead at all. So I'm doing them totally ultrasound free, which is not a usual case, or had not been a usual case in the United States for people to do this type of surgery. And so, our goal was to try to just present a new concept to a different audience to see if we could maybe try to change the needle on that front. And so that's been a fun journey. And Dr. Lamb has been a terrific partner. And, we've got this course coming up anyway. So it also, if you do something fun, it brings you to other people who you can partner up with, and kind of have even more fun when you're doing things together with people.
Thank you, Dr. Chi. Do we have any more questions or comments on the article before we end our meeting?
No, I just want to thank Dr. Chi for joining us. I almost feel like he's a regular here at UCI now. He gave us grand rounds. We're going to have to make him part of the faculty. Although I'd like to make that formal, but at some point maybe we can get him over here. He's doing brilliant, innovative work. And I just want to echo what he said. We do things that take years, that I've been working on literally for a decade plus, and are still not ready for prime time. I'll also tell you that when you change any standard of care, even moving the needle just a little bit, the powers that be don't like it. It insults their expertise. You're going to put a little nick in their ivory tower, and they want to keep that pristine. So there's a lot of resistance to new things. So that's why it's sometimes very hard to publish things that are clearly the right path. And I think that the application of ultrasound in this application and some of the others that Dr. Chi talked about during his grand rounds or grandest rounds presentation are really obvious to me. I just agree with him. He's a visionary, and I see where he's going with this. But meeting resistance does not mean you're wrong. In fact, Dr. Klayman taught me that your idea that meets the most resistance, where really people tell you that you're a friggin' idiot, are really the ideas that perhaps you should think about the most, because those are the ones that really insult the standard of care. Now, in my case, occasionally you are a friggin' idiot, but sometimes you've just struck a nerve. And with those sage words, I think we can say goodnight. Any other questions before we say goodbye? No. Could I ask the UCI team to please stick around for 1 second? Good night, everybody. Thank you.
Hey, thanks for having me.
Thank you. And
That doesn't include me, does it?
Yes, it does. Yes,
Okay,
it
I'm
does.
sorry.
So this is, yeah, please. Peace and love, my brother. Good job, by the way. You see, you did a great job.
Thank you. Good night.
Good night.
So this is an amazing exercise, but this is the worst turnout we've had in a long time. We can fix that. So I didn't tweet anything, and usually I do. There were no lift fellows on this, and usually we have, a lot of the older lift fellows. So as good a job as we did, we didn't have the kind of impact we could have, and it's not a big deal. Just next month, we have to get it back up to 30 to 40 people, and I think we just need to get the word out. So if you guys can help me tweet this a little bit next month, and we'll talk. Do we have a lift fellow like spam email where we have to generate that so that all the old lift fellows, not only can they come, but they should be, we should request that they bring some people who might be interested.
So a few things,
yeah,
for sure. It's something that we kind of thought about throughout the night. And, the thing that was the most painful was that it was such a good presentation. We had great faculty. We had,
yeah, Tom does a great job. That was amazing.
So a few things that we're going to do. We're going to be meeting with the person who does the grandest rounds with Dr. Clayman, the social media person, really seeing what we can do to kind of reach out to students. Another problem that we kind of ran into is that a lot of the fourth years from last year have not graduated into residency. So now our task is to really target the second years that are now third years to be coming out to this. So that's something that Kaylin, Rohit, and I are going to work really closely to make sure that this we get a much better turnout because,
Yeah. And just to add on to that, but I think it's also valuable, maybe we'll start reaching out to other urology interest groups because, this is a very valuable discussion. We had like one of the, top faculty in this field. And so I think that's a great idea. And I think we'll definitely do that moving forward as well.
Dr. Stephanie, you mentioned you talked to other program directors or other programs. Maybe we can ask them to, maybe we create some kind of a marketing material, flyer, digital marketing flyer that they can distribute to their medical students or their urology interest group. I just think it's so great what we've done here to not have more people get a positive impact. I'm sure people would want, if they heard about it, they would want to be on it. So let's just see if we can't focus on getting it out and about because it's a great meeting that I really enjoy. And I love hearing the medical student perspective. It makes me smile to see how they think and how they're evolving. It really does.
I can touch base with the Society of Academic Urology too, because they've got all the list of the coordinator or, coordinators and everything like that. But I think they would, maybe there's somehow we can even advertise on there as well.
Yeah, if they're willing.
Yeah, but we'll figure something out because I just don't think people are aware as much. And so I think it's great, but we can brainstorm and get some things out. So I think, yeah.
What's next month's topic? I forgot.
That's a good question.
I'll check right now.
We follow the same topics as the grandest round. So whatever the overarching theme for that month is.
Next month,
it's kidney, right?
Oncology, kidney, renal, pelvis, and ureter.
Right. So it's actually a much bigger month because GU trauma and benign stuff like this doesn't always attract as much as cancer. So we have an opportunity to get a bigger audience for next month. And yeah, we'll just make sure it gets out and about because we're doing a great thing. You guys did an awesome job. It was smooth as silk, beautifully done, nicely executed. We just need a little more audience.
And Dr. Stephanie, Kaylin, Rohit, and I will kind of interface with you.
That's great.
If you want us, you're such a creative mind in terms of marketing and reaching out to other institutions. So once you get those emails, or you can kind of,
you guys, I'm happy to meet with you guys with Sam or Samantha. If you guys are going to meet with her, I'm happy to join in. So you've got my email. Just email me, and then we can help coordinate, get everything together. But yeah, I agree. We can do it.
Thank you, Dr. Stephanie.
You're welcome.
Thank you.
All right. Everybody, watch. I'm going to do a magic trick. I know how to disappear. Watch.
Bye, guys. Have a good night.
All right. See ya.